Welcome to the first CME lecture for year 2021. So we thought of discussing the primary prevention, targeting on the primary prevention of cardiovascular diseases. So I thought of discussing how to prevent the first heart attack. So it's so important because this is the number one cause of death all over the world, including Sri Lanka. And if you take the statistics, in 2017, about 17.8 million people have died of cardiovascular diseases. And the important thing is there's 21% increase in the cardiovascular deaths over the last decade. And they expect it to be rising by the end of 2025. We'll be getting about 23 million people dying of cardiovascular diseases. And even in Sri Lanka, if you take causes of death in all age groups, the number one cause is ischemic heart disease, and the second one being the stroke, and third one diabetes. All these are non-communicable diseases. And even in premature deaths, the number one cause is ischemic heart disease. So if you see the slides, you can see clearly the diabetes has jumped from number 5 to number 2. There's exponential rise in the incidence and prevalence of diabetes, and about 80% of diabetic patients, as you know, they die of a heart attack. So if you take all the deaths in Sri Lanka, about 40% of cardiovascular deaths are due to cardiovascular disease itself. So that's the number one cause, as I told you earlier. I would like to discuss this with a clinical scenario. A 45-year-old asymptomatic male, just imagine this patient is coming to you, who has got type 2 diabetes for 8 years, hypertension for 5 years, and who is really worried about the risk of a heart attack. And because his elder brother has just died of myocardial infarction at the age of 50, and he takes occasionally alcohol, smokes about 7 cigarettes a day. He has been taking metformin 1 gram twice a day, losartan 50 milligram twice a day, and his blood pressure in the clinic was 140 over 90. BMI was calculated at 29, HbA1c 7.5, and LDL level is 140. So his main question is, how can you minimize his cardiovascular risk? Doctor, how can I prevent me getting a heart attack? So if you go through the statistics, very unfortunately, about 4 in 5 deaths of due to non-communicable diseases occurring in low and middle income countries. So that's a huge problem. Unless we take action, so we will be in crisis in the near future. So this actually shows the trends in diseases in Sri Lanka. The hospital admissions, if you see the hospital admissions due to malaria and infectious diseases is significantly rising, but the admissions due to diabetes and ischemic heart disease continue to rise over the last so many years. So this will continue to rise unless we intervene. So if you consider risk factors, as you all know, I'm not going to go through the whole thing, but you have traditional risk factors as well as non-traditional risk factors, so which we need to assess. But the important thing here is to identify the modifiable risk factors and try to modify them and minimize the risk of a cardiovascular event in the future. Then the question comes, why we are affected so commonly? Why South Asians, not the Westerns also? There are so many explanations to this answer, to this question, and mainly the risk factors of coronary artery disease. As you know, with the urbanization, industrialization, globalization, we are more at risk of developing ischemic heart disease. We become more sedentary lifestyle, as well as we lack public policies in the prevention of coronary artery disease, and we don't have we don't have real socio-economic status, and our education of people among the health practice is poor. So that's another reason. There are some behavioral causes, like we take very unhealthy diet and tobacco use, psychosocial factors, and sedentary lifestyle, as I told you. And the physiological risk factors like dyslipidemia, obesity, hypertension, and diabetes, the incidence of these risk factors are rising day-to-day basis. The other interesting thing, if you see The IUGR or maternal malnutrition can actually increases the risk of cardiovascular event in the children or when they become adults. So there's a hypothesis, Bakos hypothesis. You can go through it, read about it, and see it's very interesting. After birth, when the fetus after birth, when you have a low birth weight, then whether you are exposed to undernutrition or overnutrition as an infant, both groups can be the can be exposed to increased cardiovascular risk here. So the question, how to prevent the first cardiovascular event in our patient and how effective is it? And most of the trials have shown actually you can prevent 4 out of 5 events. That's 80% reduction of cardiovascular events if you adhere to these preventive measures. And even if this trial shows about 70 to 85% of risk reduction or the cardiovascular death reduction in these patients with the mortality reduction of 56%. But how much people adhere to these preventive measures, that's the most important thing. In this trial, the percentage of people who have adhered to these preventive measures were less than 10%. That's the main problem, because these people are healthy individuals and they don't want to listen to health professionals and adhere to all these restrictions in life. But do we have enough evidence at the moment? Yes, we do have evidence, and as I told you, we need to take an action early. These documents actually describe most of the statistics in Sri Lanka. You can actually download and read about all the trials which we have conducted and the statistics around this subject. This slide shows the Life Simple 7. This was actually introduced by American Heart Association some time ago, and on top of that, so last year they introduced the first time the comprehensive guidelines on the primary prevention of cardiovascular diseases, which I have okay. So this actually says the ABCD approach to primary prevention of coronary artery disease. Now, take A, so we need to assess the risk. There are so many risk estimators introduced by different group of people, like Framingham risk score risk estimator, ACVD risk calculator, so on and so forth, just to risk stratify the risk of a cardiovascular event in your particular patient and coming next 10 years or so. But none of these risk calculators have been validated in South Asia. So we have to use one of them. Now, if you calculate the risk in our patient, if you use the Framingham risk score, his 10-year cardiovascular risk comes over 30%. But if you take the ACVD risk calculator, which was introduced by American Heart Association, he carries a 24% 10-year cardiovascular risk, which is very significant. If you take more than 10%, you take it as a significant cutoff value. So according to the risk, this slide shows the risk is less than 5%, you take it as low risk, and more than 20%, as I told you, is high risk. So in between is borderline or intermediate risk of cardiovascular event. And this actually ACVD risk calculator to your smartphone, the Apple or Android data, as you can see here, that you can calculate their cardiovascular risk. In addition, there are things called risk enhancing factors in clinical practice. So we don't actually go by the guidelines alone. So you need to go through the history and see whether your patient is having any risk enhancing factors like family history of premature cardiovascular diseases, primary hypercholesteremia, metabolic syndromes, chronic kidney disease, or inflammatory diseases like arthritis. They all add or increase the risk of a cardiovascular event. What is the place of coronary artery calcium score? That is actually recommended to use in patients who have borderline risk, if you really want to see whether you have any coronary plaques or atheromatous plaque in your coronary arteries. But the issue is coronary artery calcium score cannot be used in young individuals. Our patients are mostly young patients in Asians, so this is not a good choice for Asians, because Young patients with a plaque, they don't have calcium because they have very young plaques with no calcification. So it's the best choice. As you can see, this is one of the CT angios done about 6 months ago. The coronary arteries can be nicely visualized. You see the wall of the coronary arteries, any calcium, any plaques, even 10 to 20% plaques can be nicely visualized. You don't need to have any calcifications to detect. So only disadvantage is expensive and it involves contrast agent. So there's a very rare chance of a anaphylaxis or a reaction to contrast agent. What is the place of aspirin? Are we going to give aspirin to our patient? So as you know, there is well proven effect in the secondary prevention. So you need to give aspirin to anybody with coming with ischemic event, whether it's a coronary artery disease or any vascular disease. But what is the place of aspirin in the primary prevention? Previous practice was to give aspirin to patients who have higher risk or more than 10% 10-year cardiovascular risk. Now with the development and new trials, as I'm going to go through briefly 3 trials, that is ARRIVE trial, last one is ASCEND trial. All these 3 trials have shown that aspirin or low-dose aspirin as a primary prophylaxis agent or primary prevention agent for the cardiovascular event is not really effective in healthy people as well as moderately high risk patients as well as diabetic patients. Basically, the aspirin should only in patients with very high cardiovascular risk, or we can actually take the cutoff more than 20% 10-year cardiovascular risk, which is not actually recommended in the guidelines, whether it's 20% or more than 30%. So it's an individual decision. That is why it has to be always, you have to take the patient, assess the patients individually and take the patient's consent and his or her views before starting aspirin as a primary preventive agent. Now the second one is hypertension. It's very important. Hypertension is prevalent and is becoming much commoner all over the world with the current definition by the European Heart Association, which is 140 over 90 or above. So prevalence in Sri Lanka is about 24%, 25%, and it's rising. If you take the cutoff of 130 by 80, the prevalence of hypertension in Sri Lanka is going to be 50%. It's the same scenario all over the world. So half of the world population is going to be hypertensive if you apply the new guidelines. Now the targets. Now in our patient, he is a diabetic, so his systolic target is going to be 130 or below, and his diastolic target should be below 70 to 79 millimeter of mercury. So it's very important that their blood pressure should be adequately under control. Our patient's blood pressure 140/90, so we need to actually start on antihypertensive or try with lifestyle modifications to bring down to 130/80, minimize the risk. Now I'll skip few slides. Cholesterol. The C is for cholesterol, it's very important. As you see in this slide, nearly 71% of the population, they have never got a lipid profile. This is from 2015 in Sri Lanka, and about 30% only they have tested for cholesterol levels. So it's very important. But the prevalence, now recent study in 2018 shows 77% of the population has some form of dyslipidemia in Sri Lanka. So we need to check or screen people and people with high cholesterol levels and treat them. Now this slide shows actually what the LDL level for a particular patient. Our patient is diabetic, less than 10 years. If you see here, his cardiovascular risk falls onto moderate, and his LDL target would be 100 milligram per deciliter or below. But the risk calculation says his 10-year cardiovascular risk is more than 20%. So spontaneously he falls into high risk category. So our patient's LDL target should be less than 70. So that's actually very low levels for someone who has never had a myocardial infarction or a stroke. Now, if somebody has had a cardiovascular event already, his or her LDL level should be less than 55 milligram per deciliter or below for very high risk patients. So we are going lower day by day. It's very important to prevent as a secondary target. Smoking. Smoking is another significant problem in Sri Lanka. About 20% of male adults are smoking currently. So if you take as a whole population, about 10 to 11% of the population smoking. Luckily, smoking in women is very low, and it's just 1.1% of the female population is smoking in Sri Lanka. So we are pumping a lot of money. We spend about 260 million rupees per year for smoking. So, and tobacco, actually, if you take this company is owned by the British American Tobacco Company, they have the 90% of the share. So when you smoke a cigarette, 90% of the money is into Europe or America. Now, most importantly here, if you see compared to 2005 up to 2018, the trends in smoking is dropping. Now, this is a good trend which we need to promote and continue. Now, when you see a patient, it's very important to go through these 5 A's. Now, first you need to ask whether the patient is smoking. If patient is smoking, then you need to advise to quit smoking, and you can assess the patient's readiness to quit, whether the patient is ready to quit. And if he is ready to quit, you can actually assess and assist them with smoking cessation. Any advice? There are some medications available. You can refer to smoking quit sessions or the rehabilitation clinics to stop smoking. It's very important. And you arrange the follow-up. So if you adhere to these 5 A's, then you can actually reduce the smoking in the patients. So it's our task is to somehow get these numbers down. Diet is another component. Very important to avoid unhealthy diet. As I told you, the South Asian diet is, I think, one of the unhealthiest diets on the planet. So how can we improve our diet? We can emphasize the intake of vegetables and fruits, legumes, nuts, especially whole grain nuts, and fish intakes. So these are the things that we should promote people to take. And the other thing is to replace saturated fat with dietary monounsaturated and polyunsaturated fat. All these food you see, they have a lot of saturated fat. So you need to but all fat is not bad. So all fats are not created equal. So there are good fat. So we need to increase the intake of monounsaturated fat, which is mainly coming from olive oil, avocado, most of the nuts. So they all have monounsaturated fats. So the worst thing to take is the trans. Then the other important thing is to reduce the amount of cholesterol and sodium intake. So you can go through the slide. These are the food actually you can promote, which are low cholesterol and low sodium. And you should at the same time minimize the intake of processed meat, especially sausages, kind of things, and refined carbohydrates and sweetened beverages. Those are the worst things that we should eat or we should give to our children. As I told you, the trans fat, deep fried foods has to be completely avoided. If you can ban these foods, actually that's the best thing to avoid or to reduce coronary artery disease in this part of the world. But if you take in good proportions, so I'm repeating, if you take in good proportions, the Sri Lankan food has been actually proven to be one of the healthiest ways of eating, which has most of the components, but we need to cut down the amount of carbohydrate we use, especially the rice, bread, fried rice, all these forms of rice flour or wheat flour has to be cut. This is a nice plate model introduced by Ministry, actually the Primary Prevention Program. This is is the way you should eat, and this gives a nice diagrammatic representation of a plate of rice. Other thing is the obesity and overweight. More than the BMI, we have calculated BMI in our patient. The waist hip ratio is proven to be a better way of assessing a cardiovascular risk. So for someone, for males, it has to be less than 0.9, and for females, it to be less than 0.8. So you can decide whether you want to be an apple shape or a pear shape. If you want to be pear shape, you are more healthy. If you want to be apple shape, you are diabetes. As another, I would say, the most important risk factor for coronary artery disease in Sri Lanka. Diabetes is so common. This is one paper article from Sunday Observer. They have observed an increase of 50%. 50% of the people in the community are unaware that they have diabetes. So when you diagnose one patient with diabetes, or when you see a patient with diabetes, there's another patient who is not known to be diabetic, but actually they are diabetic. And the prevalence is gradually rising. The very recent study done in Colombo, they have shown about 27% of the population has high blood sugar values. Either they are pre-diabetic or diabetic. So all pre-diabetics will go to diabetic range unless we intervene them very early. So we have a huge population of diabetes, about 4.5 million diabetic patients in the country. Now, when we talk about risk reduction in diabetic patients, it's important that the medications are started early. So the metformin has been tested and proven to reduce cardiovascular events, and that is a very good way of reducing a cardiovascular event. The second medication I want to emphasize is this SGLT2 inhibitors like empagliflozin, dapagliflozin, or canagliflozin. They have been proven to be reducing a cardiovascular event as a primary prevention agent, as well as a secondary prevention agent, those who have had ischemic event or those who have had heart failure. So this trial, the EMPERAGE trial, shows that the group who has been treated with empagliflozin is showing a significant reduction in the event rate as a primary prophylaxis agent, and they reduce hospitalization as well. So the guidelines, now the SGLT2 inhibitors are coming as a first line indication for diabetes with metformin. The final one is the physical activity or exercise. It's very important that we everybody engage in aerobic activities, aerobic exercise. So the recommendation from WHO and other heart associations is to do at least 30 minutes of moderate intensity aerobic exercise at least 5 days a week. So in total it comes to about 150 minutes per week. But if you engage in vigorous physical activity, you can reduce to 25 minutes up to 3 days. So in total 75 minutes of vigorous intensity exercise per week. It's not an easy task, but these are the targets. At least even if you can't match the target, if you do some physical activities whenever possible, whenever time permits, is very important in the prevention of not only ischemic heart disease, all the other cardiovascular diseases as well as malignancies. So this has been benefits of exercise is not only to prevent ischemic heart disease. Now, with aerobic exercise, it's very important that you engage in some muscle strengthening exercise, like high intensity exercise, at least 2 days a week. So when you go to gym, you can do some moderate weightlifting. Moderate weight is actually recommended. That has to be done at least 2 days a week. So my 10 take-home messages to minimize the cardiovascular risk in our patient. First one, we can promote a healthy lifestyle throughout the life. And this is the most important way to reduce cardiovascular risk. And it has to be a team-based care approach, which is an effective strategy with the patient. So always you discuss with the patient the ways and means of minimizing the risk of cardiovascular event. And we need to risk stratify all adults between the age of 40 to 75 for 10-year cardiovascular risk. Even if you reduce this cutoff to 30 years, I think that's more rational. We can start screening population from the age of 30 years to 75 years. So it has to be done on annual basis. All adults should be consuming healthy diet and maintain healthy body weight. Should engage in aerobic exercise and try to match the WHO recommendations. For diabetics, it's very important that the diet and lifestyle modifications are essential. As I told you earlier, metformin and SGLT2 inhibitors will be the first-line medication in the form of primary preventive agent. So be assisted and strongly advised to quit smoking. So that's very important that we try to stop smoking in our patient. Aspirin only if the patient is falling into high risk category. So our patient actually his risk is more than 24%, 10-year cardiovascular disease. So it's reasonable to start on aspirin after discussion with the patient about the risk of increased bleeding. Statin therapy, depending on the risk category, whether they fall into high risk or moderate risk, and you can decide whether you are going to treat with moderate intensity statin therapy or high intensity statin therapy depending on the risk category. So our patient needs high intensity statin therapy. Non-pharmacological and antihypertensive therapy to achieve the blood pressure target of 130 by 80. So those are the 10 take-home messages to minimize. So hopefully if you adhere, you can actually prevent, as I told you from the beginning, it is possible to reduce the cardiovascular event by 80%. That's a huge amount. So at least we'll be somewhere there if you try to adhere to this healthy behavior. Thank you. Just keep on walking. Thanks.